And another realistic problem that you're going to face in the clinical practice is that hyperglycemia between meals. That's very common, where your drugs may not be that effective, but the patient may have an okayish fasting and postprandial value, which means that may be okay, but there will be a lot of hyperglycemia between the meals. The levels will be soaring between the meals. So remember the fact that you're not going to spend the entire day by eating continuously 24 hours. The in-between meals is the time where the patient spends most of the time, basically. So if that values are high, that's going to result in definitely soaring HbA1c, because the mean blood glucose over the day is very high. Definitely HbA1c will be very high as well. So this is very important to find out, and the gold standard for finding out this kind of problems is CGM, that is continuous glucose monitoring. But in resource limited settings, you can do a random blood glucose in between the meals to find out the issue as well. And third one, it could be patient related or doc related problems, where the patient would have been diagnosed with diabetes mellitus maybe recently, plus most importantly taking medications recently. So either way, the patient has been recently diagnosed with diabetes, taking medications only for a short span of time, or patients have been diagnosed with diabetes a long back ago, but taking medications only for the last 1 or 2 months, plus doing HbA1c in this scenario. Typically, within 3 months of starting medication. This could be patient's problem or doctor's problem. Either the doctor's doing too fast HbA1c values, or the patient is not taking medications, only last 1 month is taking medication and doing an HbA1c. So in this setting, the fasting and postprandial values will be normal because the patient is taking medications. And the HbA1c values will be very high because you are doing very early, before the stipulated time. So at least 3 months of starting the medications is where you have to do the HbA1c value. So this could be either problem, patient or doctor-related problem. So this is a very common scenario we encounter again. And patient-related factors that cause lower HbA1c than expected, of course, hypoglycemia between the meals. As I told you, in between the meals is the time where the patient spends most of his day. So if that values are consistently low throughout the day, then overall mean blood glucose will be low, HbA1c will be low, but the patient may be having okayish HbA1c, fasting and postprandial blood sugars, because of variety of reasons like counter-regulated response and meal-related response. But in between the meals, it will be persistently low. And the patients may not even experience the symptoms because of hypoglycemia associated autonomic failure, the mechanism of which we'll be discussing subsequently in the hypoglycemia chapter. So a lot of things are there in this, which I'm not going to discuss subsequently. If the patient has hypoglycemia between the meals, the HbA1c levels may be falsely lower than the fasting and postprandial. And at the same time, if the patient is having or had a recent blood transfusion, so in this condition, the new blood cells, new RBCs that are coming in the form of transfused blood will not be having a high level of glycated hemoglobin, and that will dilute the glycated hemoglobin that is present in the patient, resulting in a falsely lower values. So all these situations has to be kept in mind before analyzing an HbA1c value. So that's why it's really important. HbA1c can be analyzed by many techniques, including liquid chromatography, and typically we use HPLC. So that's the best, where you can tell the accurate value of HbA1c. That's called high performance liquid chromatography. Apart from that, you have a lot of other methods where different laboratories use. And there are some other values that are closely related to HbA1c. Like for example, you have a fructosamine. What do you mean by fructosamine? Any protein that is glycated is what we refer to as a fructosamine. Basically speaking, even HbA1c is also a fructosamine only, but since it's been given a different name, we're not going to call HbA1c as a fructosamine. The best example for a fructosamine is glycated albumin. Glycated albumin is a best example for fructosamine. Albumin has one advantage, and at the same time it has disadvantages as well. One advantage is the fact that the turnover is actually rapid in the setting of albumin, which means the turnover time is only 28 days as far as albumin is concerned. Which means whenever you do a glycated albumin or a fructosamine, it's going to reflect the mean blood glucose over the past 2 to 3 weeks, not past 2 to 3 months. It's going to reflect the MBG over last 2 to 3 weeks. And it comes with its own problems, because there are a lot of conditions where you can have low albumin and you can have a falsely low fructosamine. You can yourself tell the conditions that produce low albumin, like liver cirrhosis, nephrotic syndrome, or patients who are having chronic inflammation because it's a negative acute phase reactant, and patients who are having protein losing enteropathies. So a lot of conditions are there which can lower the albumin and produce falsely low glycated albumin. And there is a conversion factor where you can actually predict HbA1c based on the glycated albumin, that is fructosamine. So the conversion factor tells it's 0.017 multiplied by the glycated albumin, that is fructosamine value, plus 1.61 is going to give you the HbA1c. That's the relationship between fructosamine and HbA1c. Number 3, it's a relatively new thing that's called 1,5-anhydroglucitol. And one interesting thing about this 1,5-anhydroglucitol is the fact that it tells you the mean blood glucose over the period of last 24 hours, that's all. But it tells you the MBG, it will not tell you the fasting or postprandial value, it tells you the mean blood glucose over the last 24 hours, that's all. And it correlates with postprandial sugar. So how I told you HbA1c correlates relatively better, even though it's not correct, relatively better with fasting blood glucose, but this 1,5-anhydroglucitol correlates better with postprandial blood glucose compared to the fasting levels. And there are some kinetics of 1,5-anhydroglucitol that you have to know. For example, it is absorbed in the PCT on the kidney. It is reabsorbed in the PCT of kidney. And please understand the fact that glucose is a competitive inhibitor of 1,5-anhydroglucitol absorption in the kidney. Suppose if glucose values are overwhelmingly high, your 1,5-anhydroglucitol will not be absorbed properly and they will be lost in the urine, which means the serum anhydroglucitol levels will be low. Serum anhydroglucitol levels will be low. And depending on how much anhydroglucitol is low, it will tell you the mean blood glucose over the last 24 hours. So it's an inverse correlation. Lower the anhydroglucitol, higher is the mean blood glucose over the last 24 hours. Because glucose is a competitive inhibitor for 1,5-anhydroglucitol for getting reabsorbed in the PCT of the kidney. More the glucose that is filtered because of hyperglycemia, more is going to be the loss of 1,5-anhydroglucitol in the kidney, in the urine. So resulting in lesser values in the serum, that will be correlating with the higher mean blood glucose over the last 24 hours. So we have discussed in detail with regards to the HbA1c, fructosamine, as well as the modern 1,5-anhydroglucitol. With this, we'll move on to the carbohydrate and glucose, because understanding this is really important, because we need to know about the mechanisms of how these machines are going to find out the blood glucose values and their pitfalls and their false negatives, false positives. For that, we need to know about this basic biochemical principles. And at the same time, for evaluating neonatal and infantile hypoglycemia, there's one important test called urine reducing substance. That's a very, very important test as far as hypoglycemia is concerned, where we have to evaluate for presence of galactose, which is also reducing sugar, and fructose, which is also reducing sugar, which can be elevated in the setting of galactosemia or hereditary fructose intolerance. So go and check your lab. There will be one test called urine reducing substance, which is very important test in the perspective of pediatric age group who are presenting with hypoglycemia. So for a lot of reasons, we clinicians have to know a little bit idea about the basic biochemistry, and that's what I'm going to do. I'm going to finish it very fast. Let us start our discussion with basic analysis on carbohydrates. What are the basic chemical formula for carbohydrates? It is CmH2O bracket N. So even though some textbooks give it as CH2O bracket N, so both are right. Let us understand this by seeing a very basic and the most abundant carbohydrate in the world, that is glucose, where M is equal to 6 and N is equal to 6. Or if you are using CH2O bracket N, you can tell N is equal to 6 as a single one. So by this, if you apply that 6 in the formula, it's going to be C6H12O6, which is the chemical formula for glucose, but it can be the chemical formula for mannose as well as galactose as well, because mannose and galactose are basically epimers of glucose. That's it. But we'll be discussing that subsequently. Don't worry about that. And this is not universal for all the carbohydrates, because there are some exceptions to the rule, that is deoxyribose, where the formula for deoxyribose is C5H10O4. It's a pentose sugar, of course, 5 carbon, so C5H10O4. So by a common chemical formula, if H is 10, O must be equal to 5, half of 10. But here O is only 4. Since it's 1 O less, that's why it's actually called as a deoxyribose in the first place. And how we are going to classify carbohydrates based on the degree of polymerization? based on the degree of polymerization, carbohydrates can be classified as sugars, which is going to have only 1 to 2 units. Either one single unit of sugar molecule or 2 units of sugar molecules combined together can produce disaccharides, which we'll be describing subsequently. Sugars are just 1 to 2 units of sugar molecules maximum. And then we have oligosaccharides, where you can have 3 to 9 units combined together. And you have polysaccharides, where you have more than 9 units combined to produce a long chain. Of course, polysaccharides are very, very important for life, but not important for your exams. So we have starch-based polysaccharides and non-starch-based polysaccharides. Starch-based polysaccharides can be amylose or amylopectin, and you have many, but amylose and amylopectin are important in living beings. That's why I'm telling that. And non-starch-based polysaccharides are basically cellulose, or it could be glycogen, where both are very, very important. Cellulose is a very important component of the cell wall of plants, and glycogen is very important storage form of glucose, a storage form of energy in any living being for that matters. And oligosaccharides, you're going to have polymerization of 3 to 9 individual sugar units to produce oligosaccharides. The best example for that is maltodextrin, which is very important for living beings as well. And we have another sugar called as raffinose, which is nothing but a combination of a galactose, glucose, and a fructose. And we have another oligosaccharide by name stachyose, which is a combination of a galactose, glucose, and a fructose. So you have 4 sugar units here, so it's an oligosaccharide. So with 1 to 2 sugars, you can once again divide these sugars into 3. One is the monosaccharide. They have only individual sugar molecules. And second, we have disaccharides, where you have 2 sugar molecules combined with each other to produce disaccharides. And we have polyols. Polyols are nothing but sugar alcohols. Alcoholic, derivative of a monosaccharide is what we refer to as a polyol, which we'll see subsequently. So monosaccharides, the classic examples of monosaccharides: glucose, mannose, galactose, whereas mannose and galactose are epimers of glucose. And we have fructose, we have ribose, we have ribulose, we have a lot of things. And disaccharides are going to have 2 sugar units linked with each other. The best examples are maltose, where you are going to have glucose and glucose combined with each other. Then we have lactose, where you're going to have glucose and galactose combined with each other. And then we have sucrose, where you're going to have glucose and fructose combined with each other. And polyols, as I told you, basically are sugar alcohols. They are reduced form of sugars which form an alcohol. So the best example for that is sorbitol, which we have discussed in detail on the polyol pathway itself already. Then we have mannitol. We can have xylitol as well. And one important property of this polyols is they are extremely osmotic in nature, and that's the reason why mannitol is being used as an osmotic diuretic as well. All of the polyols are generally osmotic in nature. These monosaccharides can be further divided based on the number of carbons they have and based on the functional group they harbor. Remember, carbohydrates and especially monosaccharides should harbor some functional group in the form of either an aldehyde group, which can be written as CHO. That's a basic aldehyde group. We know the basic chemistry. And we have a ketone group, which can be written as C double bond O. So this is a classic ketone group. So the functional groups that are present in monosaccharides could be an aldehyde group or it could be a ketone group. And this presence of functional groups, especially if they are free, is the one that makes the sugar reducing. For example, I told you all the monosaccharides will have free functional groups in the form of either aldehyde or a ketone. That's why all the monosaccharides are basically reducing. So glucose, mannose, galactose, fructose, ribose, ribulose, then xylose, all these sugars are basically reducing sugars. But if we take disaccharides, of course, maltose and lactose are reducing sugars without a doubt. But on the other hand, sucrose is not a reducing sugar. That's the most important point actually. Among all the sugars that you're going to see in your biochemistry book, sucrose is the one that is a non-reducing sugar, because you should have a free functional group to make the sugar reducing. What really happens is the fact this functional group will be engaged in the bond formation between the two sugars. In case of sucrose, which means that's what we call as an anomeric carbon. That anomeric carbon is the one that will not be free there and will be engaged in the bond formation. That's the reason that makes sucrose a non-reducing sugar. Very, very important point. Apart from that, all the other monosaccharides and disaccharides I mentioned are actually reducing because they contain the free functional groups, either aldehyde or a ketone. Based on the number of carbons, you can tell whether it's a triose if it's a 3-carbon unit, or you can tell it's a pentose if it's having a 5-carbon backbone, or you can call it as an hexose if it's having a 6-carbon backbone. Or it is more also, you can have more carbon units also, but these are basics. Based on that, I can derive certain things. For example, let us start with the glucose. Glucose is basically an aldohexose because glucose is going to contain 6 carbons, which means it's an hexose. And the functional group that it's going to contain is an aldehyde group. So that's why I can write glucose as an aldohexose. And remember the fact that its epimers, galactose as well as mannose, will be aldohexoses as well. And let us go for the fructose. What is fructose? Fructose is once again a hexose sugar only, but the functional group that it's going to contain is the ketone group. So that's why it's a ketohexose and not an aldohexose. Number 3. What about ribose? Ribose is basically a pentose sugar. We know that because it's going to contain a 5-carbon. And the functional group that it's going to contain is the aldehyde group. So that's why I can write it as aldopentose. Then we have a xylose. Xylose is another example of a aldopentose. And we have a ribulose. Ribulose or a xylulose. Xylose is also a pentose. It's a 5-carbon sugar only, but it's going to have a ketone group in it. So since it's having a ketone group as a functional group, it will be called as a ketopentose. And similarly, we have a 3-carbon sugar that is glyceraldehyde. It's a 3-carbon sugar where we studied a lot about this glyceraldehyde 3-phosphate in the past. So glyceraldehyde is a 3-carbon sugar. The name suggests it's aldehyde and it's a 3-carbon backbone. So it's a triose. So since the functional group is aldehyde, it's a aldotriose. Similarly, you have a dihydroxyacetone, which is nothing but a ketonic form of a glyceraldehyde. That's all, dihydroxyacetone. So which means it's a triose only, but it's going to have a ketone group as a functional group. So that's why it's a ketotriose. So and so on, you can write any number of combinations. So this is how you classify the monosaccharides basically based on the functional group and based on the number of carbons they're going to have. And this is not it. We have to discuss about certain other features like chiral carbon as well. For that, we need to know the structure of this glucose. So first, let us take a common molecule that is glucose and analyze its structure. And what I'm going to teach you is very, very basic organic chemistry, which many of the students are currently learning in the 10th standard and the 11th standard itself. So it's nothing big that I'm going to teach. First, let us start with the basic structure of glucose, which is going to have an open configuration like this. And this kind of open configuration, we are going to call it as Fischer's conformation or Fischer's configuration. Whenever I write glucose in closed configuration, that will be called as an Haworth projection, which we'll be discussing in some time. So glucose is a hexose, which means they're going to have 6 carbon, and it's an aldohexose, which means they are going to have an aldehyde group, C, H, and O. The carbon that is having the functional group will be called as the first carbon, that is C1, and I can name the remaining carbons as C2, C3, C4, C5, and C6. In this, if you notice very carefully, the first carbon and the last carbon, that is C1 and C6, will be called as achiral centers, which means they will be symmetric in nature. Either they will not have all 4 sides attached with each other, or even if they are attached on all 4 sides, they will have some symmetric groups on either side. So let us understand what is that. So first and the last we'll be calling as achiral centers or achiral carbons and they are symmetric in nature. The remaining 4, that is C2, C3, C4 and C5 in glucose will be called as chiral centers or chiral carbons, which means they are asymmetric in nature. So let us understand that. So let us take a carbon in an organic molecule like glucose and let us assume on all 4 sides it's attached with some groups. If all the groups on all 4 sides are different, this will be called as a chiral carbon or otherwise an asymmetric carbon, because all the 4 sides that are attached are having different groups. For that matters, this could be H, this could be OH, this could be CH2, this could be probably CH2, CH2, CHOH, maybe the remaining R group of that molecule. So fine, so it's completely different. All 4 sides are having different attachments. So that's why this is a chiral carbon, asymmetric. On the other hand, let's take a simple example. That's the 6th molecule of glucose, which is basically achiral and symmetric. So that is CH2OH. If you write the configuration, it will be CH2OH. And on the other side, the entire glucose, the remainder of the glucose molecule structure is attached. So that's the R I'm drawing here. So you're having symmetricity on at least one side. So this is basically an example of a achiral center that is nothing but symmetric carbon or an achiral carbon for that matters. So the concept of chiral centers are very important because this is the one that is going to give rise to the formation of enantiomers. This is the one that's going to give rise to the formation of epimers, and this is the one that's going to give rise to the formation of the anomers as well. That is your beta and alpha configuration. So we'll be discussing in some time, in 2 minutes max. And especially the last chiral carbon is really important. The last chiral center, the last chiral carbon is the most important chiral carbon because that's reactive, point number 1. So especially when you suspend glucose-like molecules in a solution, they form cyclical structures. And the reason is because the last chiral carbon is reactive and the OH group is reactive, and they produce a nucleophilic attack on the functional group. So what really happens is this H will get transferred here, that becomes OH, and now the C of the last chiral carbon will be bonded to the C of the functional group through the intervening O, oxygen. So they form a cyclical structure, like a pyranose, which we'll be discussing sometime, and that will create a new chiral center of the first carbon, which we'll be discussing again in the anomerization. And that's really important. That's why the last chiral carbon that in glucose is the C5. That's the most important. And the orientation of OH on the last chiral carbon will tell you the molecule's configuration, like whether it's a D configuration or whether it's a L configuration. Suppose if the OH on the last chiral carbon, if it's on the right side, will be called as a D type of configuration. And if it's on the left side, will be called as L type configuration. You can remember that L stands for left. So if OH on the right, D configuration, OH on the left, L configuration with respect to the last chiral carbon. So the last chiral carbon has so much of significance. It's the one that's responsible for the formation of cyclic structures. This is the one that gives the configuration of that particular molecule. In this example, I have drawn the D-glucose for that matters. The image that is showing the D-glucose because the OH group is on the right side, on the last chiral carbon. That's why. Then let us move on to the concept of enantiomers. Once you have understood the concept of chiral carbons, enantiomers are very simple. Basically, enantiomers are mirror images of each other. And mirror images in the sense, if the first and sixth are already symmetric, producing a mirror image will not create any difference at all. But the real difference you will be noticing at the chiral centers only. That is C2, C3, C4 and C5 in the setting of glucose molecule. So which means all the orientation at the chiral centers will be reversed in a mirror image. So that's what we call as an enantiomer. So already C1 and C6 are symmetric in open configuration, so there's not going to be much difference. But the chiral centers orientation will be completely flipped in a mirror image. So what I can write is the fact that all chiral carbons will have different orientation, which means orientation is reversed or flipped at all chiral centers. That's the exact mirror image. Clear? So which means you can say that here H is here, OH is here. That's exactly opposite there. So similarly, at every chiral center, the orientation is flipped, and that's what we call it as a enantiomer. And obviously, depending on the OH position on the last chiral carbon, your nomenclature will change. So since OH in this particular compound is on the right side and it's a glucose, it's called a D-glucose. And in its mirror image, OH must be, because it's a chiral center, asymmetric center, OH should be flipped on the left side. It's called as an L-glucose. That's all. Which means L-glucose and D-glucose are basically mirror images of each other. And at the same time, they have the same chemical formula. They don't have any different chemical formula. And more importantly, they are same sugars. And there's no difference. The properties of D-glucose and L-glucose will not be different at all. They're going to be the same sugars. So what are enantiomers? They are exact mirror images, and the orientation at all the chiral carbons will be reversed. There's no point in telling about the first and the last because they are already symmetric. Even if you flip, they're going to be the same. But the C2, C3, C4 and C5, the orientation is completely reversed and at all the chiral carbons. And they are same sugars with the same chemical formula. Fine. Then we are moving on to the concept of epimers. Epimers are basically different sugars but have the same chemical formula once again. But what are epimers? Epimers will differ in the orientation at only one chiral carbon. It's very, very important. If you have difference in the orientation at all the chiral carbons, that's a mirror image, that's an enantiomer. If you have difference in orientation at only one chiral carbon, that is an epimer. So let us see what's happening here. So if we take a glucose molecule, this is a D-glucose. Why it's a D-glucose? Because OH at the last chiral carbon is on the right. So that's why it's a D-glucose. Now, if you take the second chiral carbon, you can see OH is on the right and H is on the left in terms of glucose. In the setting of mannose, your H is on the right and OH is on the left, which means it's flipped at the level of C2 position. So that's why this is a C2 epimer of glucose. That's what we call it as a mannose. It's flipped or it's changed only at one chiral center, not at all the chiral centers. Similarly, if you take galactose and you compare it with glucose at C4 position, in glucose the OH is on the right and H is on the left, but whereas in galactose, H is on the right and OH is on the left, which means at only one chiral center, the orientation is reversed, remaining everything is the same. So which means galactose is a C4 epimer of glucose. And please understand the fact all of these are D sugars. Why? Because OH is on the right. That's why all these things are D sugars. OH is on the right on the last chiral carbon. That's what makes sense. And you also have to understand the fact that epimers are different sugars. They are not same sugars. Epimers are completely different sugars in terms of their properties, in terms of their chemical reactions. They are different sugars. They are not the same sugars. And they behave differently. Enantiomers are same sugars. There's no difference. But epimers are actually different sugars. How can I understand this easily? So when you take this pencil and put it in front of the mirror, both will look exactly the same. There will be no difference. Actually, in fact, both are same pencil. But if I take this pencil and I take another pencil and I take this nib and keep on the top, the components are the same. But I've changed the orientation of this nib and I've kept on the top. So which means I'm changing orientation at only one place. But the property of this pencil is different, which means I'm not able to write this because I don't have the nib, which is here. The orientation is flipped. So if you change the orientation at only one chiral carbon, it will become a completely different sugar. That's an epimer. But surprisingly, they will have the same chemical formula. In this example, all these three sugars, that is mannose, glucose as well as galactose, have the same chemical formula of C6H12 and O6. There is no difference at all. It's only about the change in the orientation at only one chiral carbon, which makes the sugar completely different. That's epimer. And epimers can have enantiomers. Epimers itself can have enantiomers among each other. For example, a D-mannose can have an L-mannose if suppose the OH group in the last chiral carbon is on the other side. It becomes an L-mannose. Similarly, D-glucose can have an L-glucose, which I have described already. Similarly, D-galactose can have a L-galactose as well. So epimers can have enantiomers. If the OH group goes to the other side, it becomes L type. Clear? So summary, enantiomers are mirror images, same sugars, same properties, same chemical formula. And the orientation at all the chiral centers is reversed. Epimers, on the other hand, will have difference in orientation only at one chiral carbon, but they are different sugars, but with same chemical formula. But they behave differently in chemical properties. And epimers can have enantiomers. And the final one is the formation of this cyclical structures. So how you form the cyclical structures? As I told you, the last chiral carbon will have a reactive OH group that's going to produce a nucleophilic attack on the functional group, which will result in transfer of this OH here, which will become CH and OH. And now there will be a bond like the CO and C bond that is happening with the last chiral carbon with the functional group. That is the first carbon. And one interesting thing that has happened here is the fact that this first carbon, which was previously achiral and symmetric, now it has become chiral and asymmetric. So that's a new chiral center being formed in cyclical configuration. So if you don't believe, you can see the cyclical configuration. This type of cyclical configurations are called pyrens because pyrens are compounds with 6-sided heterocyclic structures with oxygen in one of the sides. So this is a typical pyren. So since this cyclical structure of glucose resembles a pyren, it's called a glucopyranose. That's all, nothing else. And if you see the first carbon, so let's come back to this. If you see the first carbon, on one side you have H and the other side you have OH, on the other side you have O, and on the other side you have the entire glucose molecule that is attached, which means definitely that first carbon has now become a new chiral center. It's a new chiral carbon. And that's going to create a lot of impact because this creation of new chiral center will result in the formation of something called anomeric carbon. So what do you mean by anomeric carbon? The carbon which was not previously chiral now has become chiral and has become a new chiral center. Such a carbon is what we call as an anomeric carbon in cyclical configuration. Clear? And based on the configuration of the anomeric carbon, you can have two more configurations. So like for example, if OH is on the down, we call it as alpha configuration. If OH is on the top, we'll be calling it as a beta configuration. So because there is a new chiral center that is formed, based on the configuration of the H and OH at the anomeric carbon, that is a new chiral center, you can have two other configurations called as alpha configuration and beta configuration. So very simple, the cyclical structures of glucose are called as glucopyranose. Once you form the cyclical structure, you are going to form a new chiral center that is on the functional group, that is the first carbon, which was previously achiral and symmetric, now has become chiral and asymmetric. And the new chiral center is what we are going to call it as the anomeric carbon. And based on the orientation of the anomeric carbon, H and OH, your configuration can be either alpha or configuration can be either beta, depending on OH is on the down or OH is on the top. So remember the fact that enantiomers and epimers can exist in cyclical forms. That's a very important point as well. For example, you can have a alpha D glucopyranose and you also can have an alpha L glucopyranose, which means I'm talking about the enantiomers here, so which can exist in cyclical forms. Similarly, epimers can exist in cyclical forms. For example, alpha D galactopyranose, and I can also write beta D galactopyranose, which means epimers can also exist in cyclical forms. As simple as that. So enantiomers and epimers can exist in cyclical forms. This is the concept of enantiomers, epimers, and anomeric carbon and cyclical forms. Cyclical forms will be projected in Howarth configuration. That's also a question. This is a Howarth projection or Howarth configuration. There are chair configurations also there, but we are talking about the Howarth configuration. That's what is going to be your exam question as well. And let us talk about the traditional tests that are going to use for detection of blood glucose or the urine glucose. In fact, initially, most of the tests will be based on detection of the urine glucose only. Blood glucose measurements are completely different, which we'll be discussing in some time. So let us talk about the urinary glucose first. And first, let us go for the Molish test, the basic carbohydrate test, which means it's a general group test for any carbohydrate. So any carbohydrate will test positive for Molish test, but only one rule, it should have at least 5 carbon or more. That's all. But what is the principle behind this Molish test? If you are adding a carbohydrate, initially you will be mixing with sulfuric acid, which is a very powerful dehydrating agent. Once you remove water out of these carbohydrates, it will result in the formation of certain compounds called furfurols, which will be then allowed to react with another substance called alpha-naphthol. Once these furfurols react with alpha-naphthol, they are going to produce certain colored products. Typically, they will produce a purple colored product, which you can see at the interface as a ring at the interface of mixing solutions as the ring in the test tube. So that's a sign of a positive Molish test. It's a group test for carbohydrates. Only rule 5 or more carbons in the carbohydrate. That's it. So then we have tests for reducing sugars as well. So we know most of them are reducing sugars, with the exception you have to remember for the exams is sucrose. Sucrose is a non-reducing sugar. I told you multiple times. So there are 2 tests for testing this reducing sugars. Basically, one is the Felling's reaction or the Felling's test, and second one is the Benedict's test. Remember the fact that Felling's and Benedict's test are based on the same principle, but even though Benedict's reagent is more stable compared to that of the Felling's reagent. So that's why Benedict's test is more popular. And remember, in the early 19th century and the early 20th century, the only way to find out the diabetic patients is by using the Benedict's test in the urine. And what is the basic principle? So it's going to detect all reducing sugars. So whenever you're going to add reducing sugars and make them react in an alkaline environment. So in Benedict's reagent, we are going to use sodium carbonate to create an alkaline environment. So they're going to produce certain compounds called enadiols. These enadiols are very powerful reducing agents. So these enadiols will then be allowed to react with the cupric ions that are suspended in the solution. Already will be there in the Benedict's reagent. These cupric ions will be converted to cuprous ions by these enadiols. This is a reduction step because we have a cool mnemonic called Leoger. That is something we have studied in the 8th and 9th standard itself, where loss of electrons means oxidation and gain of electrons means reduction. Here what's happening is 2 plus is becoming 1 plus, which means 1 positive charge is lost, which means 1 negative charge should have been gained. So here 1 electron is gained, that's why 1 positive charge is lost. So it's cuprous, it's a gain of electrons, which means it's a reduction step. So this is getting reduced and this cuprous ions will form cuprous oxide which will precipitate. And depending on the amount of reducing sugar in the solution, the amount of cuprous oxide will increase, resulting in formation of different colors, where you can actually quantify to an extent. So that's why Benedict's test is considered as a semi-quantitative test. It's not totally qualitative, it's a semi-quantitative test. Remember, Molish test is a totally qualitative test. It's not a quantitative test at all. But Benedict's is a semi-quantitative. You can easily understand by writing WebGR, where if you have a blue color, which means the test is negative and you don't have any reducing sugar in the solution. For example, if your testing solution is urine, which means urine does not have any reducing sugar. If you have a green color, in this example, I can tell you have a trace sugar in the solution. Or if you are having a yellow color, yellow colored precipitate, then I can tell you have low amounts of sugar, not trace, not very high also, low amount of sugar is present in the solution. If you get an orange colored precipitate, that tells you you are having moderate amounts of sugar in the solution, that's reducing sugar in the solution. And if you get red colored precipitate, I can tell that the solution contains very high amounts of reducing sugar. So it's basically a semi-quantitative test, not a totally quantitative test, but it's basically a semi-quantitative test. Apart from that, you can have some other tests that are important for carbohydrates. One is the Barfoed test. Barfoed test. Barfoed test again is for reducing sugars only, but it can differentiate between reducing monosaccharides versus disaccharides. In exams, if they ask you have to tell that the test will be positive for monosaccharides and not for disaccharides, but in reality, monosaccharides will react faster and disaccharides will react very slowly. Both can produce positive, but monosaccharides are the ones where you are going to get faster reaction, faster positivity. But anyways, in exam you answer, it's a test to differentiate between monosaccharides and disaccharides, where monosaccharides will be positive, disaccharides will be thought to be negative as far as exams are concerned. Then we have a Selivanov test, which is a test to differentiate the functional groups between the monosaccharides. For example, whether it's a ketose sugar or it's a aldose sugar. We are going to differentiate between a ketohexose and a aldohexose. The best example for ketohexose is a fructose, which will show a positive reaction. And the best example for aldohexose is a glucose or probably a galactose, which is typically going to show a negative reaction as far as the exam is concerned. But once again, I have to tell that fructose is going to be fast reacting in Selivanov test, whereas glucose and galactose can produce a positive test, but it's going to be taking a very long time, very slow reaction. But for exams, you have to know that Selivanov is to differentiate between ketose sugars and aldose sugars, whereas fructose is going to show a positive test, whereas glucose and galactose, those are aldohexoses, so they're going to produce negative test. And finally, we have osazone formation. The principle is very simple. Even if you ask a 11th standard kid, they will tell how osazone is formed because their chemistry is containing all this information. So let us take glucose, fructose, monosaccharides, and certain disaccharides like maltose and lactose. And once they are made to react with compound called as phenylhydrazine. So you're adding phenylhydrazine to the solution. So they're going to produce certain compounds called osazones. Osazones are special because they have some peculiar properties, which I'll tell you in some time. So in this example, you can produce a glucosazone or a fructosazone. And for disaccharides, you can produce maltosazone, and you can produce lactosazone as well. And of course, there is galactosazone also. But there is one osazone that is not there, that is sucrosazone. Most of the times, the sucrose will be negative only, will not react with anything because of its unique property that anomeric carbon is used for bond formation. That's the reason. Clear? So these osazones, once they are formed, they have some well-defined shapes which can be observed under the microscope because they form crystals which have well-defined shapes that can be looked under the microscope, especially in the high power. So this glucosazone and fructosazone will be having a characteristic broom-shaped crystallization, whereas maltosazone is going to have a sunflower or petal-shaped crystals under the microscope, and in lactosazone, you are going to see a hedgehog or a powder puff appearance of these crystals. And what will you see in galactosazone? Galactosazone will typically produce this rhomboid plates-like appearance. This will be the shape of the crystals. So the shape of the crystals are very important as far as exams are concerned. They are many times asked in multiple exams, basic biochemistry, osazone formation. Even 11th standard and 12th standard kid will easily tell this. They have fixed shapes, fixed properties. That's osazones. When you add these sugars with phenylhydrazine, you will result in the formation of osazones. And please understand the fact that sucrose will not produce ozone, which means there is no sucrosazone. Very simple. And finally, I'm going to tell only about the test for ketones. I mean, these are the principles which we are using even now. So we know the test for ketones can include the urine sample or the blood sample. Of course, the blood sample is the one that is preferred right now, where the blood samples will be measuring the beta hydroxy butyrate. So that is more accurate in the setting of diabetic ketoacidosis, which we'll be discussing subsequently. And the urine samples can measure acetoacetate and acetone only. They cannot measure the beta hydroxybutyrate because they utilize a principle called nitroprusside principle. They utilize this nitroprusside principle, and that is the basis of one important test called Rotheras test. And the same principle is used by the dipsticks currently as well. So the nitroprusside test can detect the ketone group, but whereas the ketone group is open in the setting of acetoacetate and acetone, but it's hidden in the setting of beta-hydroxybutyrate. You can go and watch your chemistry books now. So that's why Rotheras test will be positive only for acetoacetate and acetone. Usually, beta-hydroxybutyrate will not react with Rotheras test and you cannot detect beta-hydroxybutyrate. So the currently available dipsticks also are going to utilize the same nitroprusside principle only, even though it's not called as Rotheras test, it's because it's a dipstick based test. So same nitroprusside principle only they are going to use, which means the urinary dipsticks which are being used in the current era also cannot detect the beta-hydroxybutyrate. They can only detect acetoacetate and acetone. Remember the fact, even though I'm going to describe in a great depth and detail in diabetic ketoacidosis chapter, but please understand the fact that acetoacetate and acetone are not that important ketone bodies in the setting of diabetic ketoacidosis. In the setting of ketoacidosis, the beta-hydroxybutyrate is the most important ketone, and the measurement of beta-hydroxybutyrate is the one that is going to give you the true reflection of how much ketosis the patient is having. So that is the reason why whenever you are seeing a patient with diabetic ketoacidosis, always go for the plasma ketones that measure the beta-hydroxybutyrate. Do not use the urinary ketones as much as possible. Urinary ketones are error prone. In the very early stages, it can be negative. And at the same time, they cannot reflect the true amount of ketosis that is going on in the body, because beta-hydroxybutyrate is the one that is maximally elevated in the setting of diabetic ketoacidosis. So measuring urinary ketones, if you are not measuring beta-hydroxybutyrate in that setting, you will not be able to know what is the background ketosis that is happening. So the magnitude of ketoacidosis will be underestimated if you are testing the urinary sample for ketones. And at the same time, this beta-hydroxybutyrate will be converted to acetoacetate with the resolution of ketoacidosis. So during the resolution phase of ketoacidosis, because more and more beta-hydroxybutyrate is getting converted to acetoacetate, the urine will show a lot of ketone bodies. So urine ketones may be persistently positive even in the setting of resolution of ketoacidosis, even after treatment. So that should not be taken as a sign of inadequate treatment. So which means it's better to avoid urine ketone testing as much as possible, which is highly inaccurate, where they can have poor detection in the early phases, where you may not be able to tell the exact magnitude of ketosis going on. And third thing, you may not be able to tell whether the ketosis is getting resolved or not, or during the resolution phase, urine ketones may paradoxically get elevated because of the increased conversion of beta-hydroxybutyrate to acetoacetate. So whenever you have suspicion of ketosis, always do a plasma beta-hydroxybutyrate, which is the most reliable test as of now. The remaining details I'll be giving in the diabetic ketoacidosis chapter. So let us see some of the images. And the first image is really important because it tells you what is the type of vacuum tender that you have to use for collecting blood glucose. It's the gray capped vacuum tender that you have to use, because that is the one that contains a very important component called sodium fluoride that is ideal for collecting samples for measuring blood glucose. It also contains potassium oxalate, of course, which is going to serve as an anticoagulant. But it can be different. It could be EDT or it could be heparin as well. But the most important component is the sodium fluoride. Why? Because RBC's only source of energy is glycolysis and glucose. So they are going to take up glucose actively and they're going to process through glycolysis and they're going to produce ATP, which is going to be the only source of energy for RBCs. Of course, unless and until you find a way to block the glycolysis, your blood glucose will be consumed by the RBCs over time, and for every hour you delay, there's going to be decline in the blood glucose by 5 to 10 milligrams per deciliter per hour. So which means it will be falsely low and will not be reflecting the actual blood glucose value. So that's why we are using sodium fluoride, where this fluoride component is a powerful inhibitor of an important glycolytic enzyme called enolase, thereby blocking the glycolysis, preventing the RBCs from utilizing the blood glucose and preventing the falsely low values that can happen if you process the sample a little late. First of all, you have to process sample as soon as possible to prevent this possible artifact. At the same time, use sodium fluoride containers, which are going to be the most accurate. Then, let us see other testing. So whatever we have discussed. So this is the Mollish test basically, where you can see the formation of the purple colored ring at the interface. Especially they are going to give a positive test for any carbohydrate with 5 or more carbon atoms. And then you have a Benedict test, which is a semi-quantitative test for any reducing sugar, not only for glucose. Blue means negative, green means trace positive, yellow means we know it is low to moderate, yellow orange means it's low to moderate amount, and red of course means high amount of reducing sugars in the sample. So usually it is used for urinary glucose measurement. Then we have the typical osazone crystals, where of course this is a broom shaped osazone crystal which will be seen in glucosazone and fructosazone. And this is a sunflower or petal shaped crystals which will be seen in maltosazone. And this is powder puff. The third one is the powder puff or hedgehog shape. This is lactosazone. And finally you have this kind of rhomboid plates, that is galactosazone. All these images are important for exams. And I've shown you the principle behind this Rotheras test. I've told you the principle, but I didn't show you the image. So this is a typical Rotheras test that is done in the urine, which is a nitroprusside based test. So they form this pink colored ring usually. That's a sign of a positive test. The same thing, the pink color formation and the intensity of the pink will give you the quantification of the ketones as well. But please understand the fact that the Rotheras test as well as the dipsticks that are measuring the urinary ketones is not able to detect the beta-hydroxybutyrate, which is the most important ketone body in the setting of diabetic ketoacidosis. So use blood tests, as I told you before. Let's conclude the chapter by seeing the methods that are used to detect the blood glucose, which are really important. So blood glucose can be measured through your famous CBG strips, that is capillary blood glucose strips, which uses the dry chemistry, which means in the strip you don't have any wet chemical agents are there. It's completely dry strip, which is having some chemical reactions that is going on when you are going to introduce blood into that. So that's what we are going to call it as a dry chemistry. But whereas measuring a venous glucose, and that's what is considered to be the gold standard basically, and all the cutoffs for diagnosis of diabetes mellitus are based on the venous standard only. That's a venous glucose. It is going to use the wet chemistry, which means they are going to use some wet reagents in the laboratory. First, let us finish off the dry chemistry. That is our CBG measurement. What's the principle behind the capillary blood glucose measurement by the glucometer? So they are going to utilize the reducing properties of the glucose. For example, glucose that is present in the blood will be reacting with a very important enzyme that is present on the CBG strip called as glucose oxidase. So it's going to use a glucose oxidase method. So and they will convert this glucose to gluconic acid, which is a very powerful reducing agent. And once gluconic acid is formed, it's going to convert the ferricyanide, which is also present in the strip, to ferrocyanide. Ferricyanide, you know, the ion is going to be in Fe3 plus form, and ferrocyanide ion is going to be in the Fe2 plus form. And of course, because of the flow of electrons, which means there will be gain of electrons, and that's what we call it as a reduction, this ferricyanide is converted to ferrocyanide. And that's what is mediated by the gluconic acid, which is a very powerful reducing agent. So let us take the famous mnemonic that is Lioger, gain of electrons is reduction. Here the electrons is gained by the ferricyanide, so that one negative charge is gained to become Fe2 plus. So Fe3 plus has become Fe2 plus because it has gained one negative charge in the form of an electron. So gain of electrons is reduction. So this is basically a reduction step mediated by gluconic acid, which is a reducing agent. So now this ferrocyanide is going to get converted to ferricyanide once again. In the process, of course, it's going to become Fe3 plus. Now in the process, it has to release the electron that is already gained in the previous step. So this electrons will flow through the electrode that is also present in the strip, and of course this flow of electrons is what we call it as a current, electrical current. That's the basic physics, and the amount of current that is detected by the electrode will be proportional, of course proportional to the amount of ferrocyanide that is formed. which is in turn proportional to the amount of ferricyanide that is formed, which in turn is proportional to the amount of gluconic acid that is formed, which in turn is proportional to the amount of glucose that is formed. So finally, we can conclude that the current that is generated in the electrode is proportional to the amount of glucose in the sample. Through complicated algorithms and calculations, we can estimate an approximate amount of glucose that is present in the sample blood. This is a very simple process. One problem is that since it uses the reducing property of glucose, other reducing agents might sometimes cross-react like galactose and fructose in the setting of galactosemia and hereditary fructose intolerance. So you have to be a little bit careful about that. Apart from that, the major reducing substance that is present in the blood is usually glucose in humans, nothing else. And venous sample is the gold standard. So venous is going to use the wet chemistry, and there are three types of wet chemistry. One is the enzymatic method, that is the preferred. One second is the reduction methods, which is not preferred nowadays. And the third one is the outdated condensation methods. Only one method is there in condensation, that is orthotoluidine method, which is completely outdated. So I can put a big cross for this. And there are two methods in the reduction techniques. One is the classic Folin-Wu method, and second one is the Nelson-Somogyi method. Once again, both are outdated methods and we are not going to use it. Why reduction methods are outdated? Because again, these methods can cross-react with the other reducing substances like galactose in galactosemia and fructose in hereditary fructose intolerance, and even high dose of vitamin C can act as a reducing agent. So in the presence of other reducing agent, they can give a false values, and that's why these methods are abolished. And these are multi-step process and you need a lot of different steps to be done, and it's very cumbersome. That's why these are outdated, and currently preferred are the enzymatic methods. There are two enzymatic methods. One is the classic God-Pot method, which is nothing but glucose oxidase peroxidase method, and second one is the hexokinase method. Let us analyze these two methods for completion's sake. And hexokinase method is the one that is currently preferred by many tertiary laboratories. What is the principle behind this God-Pot method? That is glucose oxidase peroxidase method. So the glucose in the plasma, that is in the sample, will be made to react with an enzyme called glucose oxidase that will be provided by the laboratory, will be present in the reagent, and which is going to result in the production of gluconic acid. We know it's a very powerful reducing agent, and it's also going to generate hydrogen peroxide in this step. But please understand the fact we are not going to utilize the gluconic acids reducing property. Rather, we are going to utilize the hydrogen peroxide that is produced in this reaction. I can tell the amount of hydrogen peroxide that is produced in this reaction will be proportional to the amount of glucose that is present in the sample originally. This hydrogen peroxide then will be made to react with an enzyme called peroxidase that will also be present in the reagent and will be provided by the laboratory, where it's going to convert this hydrogen peroxide to hydrogen and H2O, water and nascent oxygen. And I can also tell the fact that the amount of nascent oxygen that is produced in this reaction will be proportional to the amount of hydrogen peroxide that is present already, which in turn will be proportional to the amount of glucose that is present in the sample. This nascent oxygen, then it will be reacting with the coloring agent that is again present in the reagent, and there are two coloring agents that will be there. One is 4-amino antipyrin and second one is the phenol. And once this nascent oxygen reacts with the coloring agent, they will result in the production of a pink colored chromogen which absorbs light at a specific wavelength, that is 520 nanometer. So which means I can tell the amount of pink color that is formed will be proportional to the amount of nascent oxygen that is generated, which will be proportional to the amount of hydrogen peroxide that is generated, which will be proportional to the amount of glucose that is present in the sample, which means the pink color is proportional to the amount of glucose. Even through naked eyes you can see this, the more the pink, the more the sample glucose is. And of course you will have a control, and that's different. That's for laboratory personnel, not for us. And this can be further analyzed quantitatively and more accurately by calorimetric methods by seeing the light absorbance at 520 nanometer. So the more the 520 nanometer light that is absorbed, which means more the pink color that is there, more the pink color means more the glucose, and based on the calculations you can tell exactly what is the amount of plasma glucose that you're having. Apart from that, second method, which is the currently preferred method, that is the hexokinase method. It's more accurate, where you're going to use the plasma glucose and you're going to make it to react with the enzyme called hexokinase, which is an ATP dependent method, and it's an irreversible step which produces something called glucose 6-phosphate. We know that. Glucose 6-phosphate will be further made to react with another enzyme called as G6PD, that is glucose 6-phosphate dehydrogenase, which is going to convert this to a 6-phosphogluconate. But remember the fact that one more very important substrate is needed for conversion of glucose 6-phosphate to 6-phosphogluconate, not only the G6PD. You need something called NADP. Some labs provide NADP, some labs can provide NAD also. But anyways, nevertheless, if you provide NADP, this enzyme will convert NADP to NADPH. And if you give NAD, this enzyme will convert NAD to NADH. Of course, you need ATP also in the hexokinase step, but that's not important for us, where ATP will be converted to ADP in an irreversible reaction. But that's not important right now. But understand the fact, this glucose 6-phosphate dehydrogenase step will be generating NADPH and NADH. So what I can try to tell is the fact that the amount of NADPH, if you provide NADP, or the amount of NADH, if you provide NAD, that is generated in this step will be proportional to the amount of glucose 6-phosphate that is generated in the previous reaction. We know the amount of glucose 6-phosphate generated in the previous reaction will be proportional to the amount of glucose that is present in the sample, which means the amount of glucose that is present in the sample will be proportional to the amount of NADPH that is generated, or the amount of NADH that is generated, depending on what you provide in your reaction. Either you provide NADPH or you provide NAD. That's what the idea is. So how you identify this quantitatively? You're going to see the UV light absorption at 340 nanometer, because this NADPH and NADH can absorb the ultraviolet spectrum at 340 nanometer. So if they're going to absorb more light of 340 nanometer, it means there's going to be more amount of NADPH and NADH that is present, which will be proportional to the amount of glucose 6-phosphate, which will be in turn proportional to the amount of glucose. So the more the 340 nanometer light that is absorbed, more the NADPH, which means more the glucose that is present in the sample. So depending on certain calculations, you can accurately determine how much glucose that is present in the sample. So that's why these venous blood glucose measurements or plasma glucose measurements are going to be more accurate, and relatively it's a one-step process. Most of the times you just put all the reagents and just do it colorimetrically, and you're going to get the blood glucose value. And please don't forget to use the gray vacuum tester, which is of paramount importance. And we are not going to use the reduction methods, and we're not going to use the condensation methods, which are highly cumbersome and ineffective, and they can give a lot of false positive results as well. And CBG is going to use the dry chemistry, but it's going to use the same enzymatic method, that is glucose oxidase method, but still it utilizes the reducing property of glucose, and that's where the problem is. It can be sometimes inaccurate, but apart from that, nevertheless, most of the machines are fairly accurate in the setting of common general population use, where the predominant reducing substance that is present in the blood is glucose only. So it's not a big problem at all. So always venous glucose is the gold standard. With this, I think we have covered in detail, and in fact a lot of detail, on glucose and insulin and all those stuff. So I hope this session will be useful, and we'll close down this session, and in the next session we'll be discussing on the pathophysiology of type 1 and type 2 diabetes mellitus and the classification of diabetes, which is more important. See you there.